Okay, I'm Bill Roy from UCLA. I think this was very enlightening, especially having a mentally ill son. It gives me a lot to think about. Question I have is, what's the criteria for how we think about the role of biology in mental illness? That I heard two sorts of arguments here. One was sort of on meta theory, Cartesian dualism, that we evaluate the whole meta theory, and if we like it, then it's okay. If we don't like it, somehow we want to change it. And the other is more on the level of pragmatics, that there are certain implications of the way we think about things, that they create stigma, or they're helpful in treatment, or they're not. But both of those, in some sense, seem secondary to really the role of explanation, and that how we explain things in I guess, in scientific terms. So the question is, what is a constructive way to think about the role of biology and medicine in this? And what would be the criteria that we might use then to evaluate ways of thinking about biology and mental health?
I'm happy to start, but if you want.
You go ahead and you start, and I'll jump in afterwards.
Okay. It's a great question. I think that I take a very functionalist perspective. So in part, the answer depends on how effectively research progresses in being able to make this useful. So I think it is clearly playing a role. I think the challenge is that we have to stop conceptualizing the role as only going in one direction. So I'm concerned by the impression people have that you have genes, biology, behavior, and that it's always in that direction. Because while that is absolutely a critical and important direction, we now have a lot of evidence that it is not the only direction. So for example, we see similar changes in brain structure and brain functioning using methods like functional magnetic resonance imaging following therapy for obsessive compulsive disorder as we see following medication for obsessive compulsive disorder. So we know, and the field of epigenetics is showing us that this is an ongoing dynamic interacting system. It is not this sort of deterministic process that occurs. And so I think that there's a big push right now by the National Institute of Mental Health to do this. It's called the RDoC, Research Domain Criteria. And it's all about identifying the neural circuits for different sort of problems in functioning. So it's not going to be disorder-based, but they're going to sort of have the neural circuitry of all kinds of negative emotions, for example. And to the extent that that can make a lot of progress, I think it helps us a lot. But until we get some of those answers, it can also slow us down a little bit because it's never going to be the whole explanation. So it is one piece in a really complex picture, and it plays a really critical role. But this idea that we only go in one direction is just, we know at this point, we have enough research to say it's clearly a fallacy.
And I would definitely agree with that. I think that is probably one of my sort of pet peeves with sometimes how this gets talked about. And so I think greater recognition of the bidirectional relationship between environment, behavior, and the brain is really, really critical here. I think it's also really important while we're being really excited, and I am really excited about some of the things that we're figuring out with regards to biological correlates and potential biological causes of different forms of mental illness, to be really honest with regard to where the research actually is. So, for example, we've been promising for decades now, literally 3 decades, that we were around the corner from being able to say what the biological cause of mental illness is. And that's actually been really well documented by a number of people. And it's not to dismiss what we've learned. I think every study that has been out there has really, in many ways, taught us that it's just so much more complicated than what we originally thought it was. And the more we learn about that complexity, I think we really are learning something. I don't think that that's a bad thing. I think we really are gaining greater levels of explanation. I saw a wonderful presentation by a schizophrenia genetics researcher who pointed out that we were mistaken when we thought we were going to be able to find single genes that would predict schizophrenia. And she said even the big genome-wide association studies, which were widely scanning lots of different genes turned out not to be that helpful, because what it now looks like is it might be that within one tiny population, for example, she studies people in Latin America who are very sort of geographically isolated, it's one type of mutation that might increase your risk for schizophrenia. But if you go look at an Icelandic population, it's a completely different type of mutation. And what those mutations may have in common is that they affect the glutamate system. How they affect the glutamate system, what the glutamate system is exactly doing, we don't fully know. We do know that looking at glutamate can provide some enlightenment on why our medication treatments for schizophrenia have not always had sort of optimal outcome, and that in some cases what we might be doing now is identifying an upstream problem before dopamine. So a lot of the research is focused on sort of what we call the dopaminergic hypothesis of schizophrenia. And I asked her when she was giving this presentation, I said, does that mean that in many ways all along when we've been focusing on dopamine, we were focusing on a biological symptom of something that is way more complex than what we once thought it was? And she says, yeah, pretty much that would be where I would conclude. So it's not that we didn't learn anything. We learned a lot in those years. But what we learned was that it's not as simple as we hoped it was going to be. And I do feel like we need to be more honest about that.
I suppose my response to the criteria for the role of biological in mental illness is that you need it. Is that you won't understand what's going on in the genetics, for instance, but in a lot else besides, unless you have a biological aspect stroke component to your explanation. But so too, you're going to need a social component, social support, or your developmental component, early losses, which are also going to be necessary if you're going to encompass some of the phenomena you're attempting to explain. And I'm guilty in a way, of course, of caricaturing my biological psychiatrist. Good biological psychiatrists are good biological psychiatrists. And medicine itself, we're likely to caricature medicine saying the medical model. Well, actually, there are very sophisticated medical models that take all this into account. A good doctor is worth his weight in gold, or her weight in gold. And so it is in this area too. So it's this movement across meanings and lacks of meaning sometimes, the lack of meaning sometimes, some people, illness just hits you. That's so very difficult. But I do want to make just one point about that, which comes back to the issue about, see, we're still so easily take up the language of symptoms. And even, it's a slightly different issue from the stigma one, but for, I think, a lot of so-called neurotic conditions, there is a fundamental question, and it's not just to do with what relieves people's stigma or what the patient wants, but it's this. It's, do you take what is presented as a condition as being something separate from this person's personality or not? It seems to me sometimes it's right so to do, and sometimes it is unhelpful so to do. And the main thing that I am interested in is whatever one might want to do strategically, there's also an underlying question about the facts of the matter. How this bit of behaviour comes to be problematic, whether or not it's segregated within the psyche as well as within our ways of thinking about it, and what to do about that, whether to go with that model or not, is a profoundly important therapeutic decision.
I'm Emily Ozer from UC Berkeley, and it's a wonderful panel, and you've done such a good job of highlighting all of the complexity in terms of definitions of disorder. It makes me think also that we haven't really, until your comment, Peter, we haven't really been talking at all about mental health, and also about, and I'm wondering, I think our field has done a better job on the disorder side than actually sort of trying to define what we mean by strengths or competencies or mental health. And I'm wondering if there's any benefit that we could have, given all of what you've highlighted here, in terms of putting more attention to what we actually mean by mental health.
Who would like to jump on that? I can say the short answer is yes. I think there would be a lot of benefit to really looking at that and trying to think what is mental health and what do we mean when we're trying to identify what are strengths that people have, and resiliency, what makes people more resilient. And I do think that might again also lend itself to looking at some of the more complex, sort of the complexity of the issues, given that I think people might be more amenable in some cases to really recognizing all of the different factors that contribute to that. But I'll see what else you all might have to say on that.
I think it is very important. It's complex, of course, and it goes back to your discussion last week about the conditions that might facilitate resilience and mental health in a community. I'm just going to make one slightly kind of eccentric point in a way, is that it seems to me that in our clinical work, the notion of strengths and difficulties is very much there, present all the time. So, for instance, I've seen many people who have really quite serious difficulties and problems, but also a quality of strength about them and of ability to face up to difficult truths and to work with others towards trying to cope with what's going on, that's very remarkable. Whereas other people with much less problem, as it were, also actually don't seem to have so much capacity to get to grips with their situation and what's going on. So it's going to be a complicated one, and I think efforts devoted to trying to articulate some of that and have debates about it are well worthwhile.
Yeah, I would certainly, absolutely agree. And I think that it's unfortunately, an error in our field frequently that when people do evaluations, which goes back to how are you conceptualizing disorder, they forget to evaluate a person's strengths, which is a sort of ludicrous idea because, first of all, you're obviously not doing a comprehensive evaluation if you don't look at what's working well for the person. But it's also very counterproductive because when I think about how I can help somebody to affect change in their life, great, let's use their strengths. Where are they coming from that what's already working for you? Then we've already got some information about what's likely to be helpful. But I think there's a larger issue to your question, which is a really important one. And in some ways, this reflects some of the issues we talked about last time as well, is that we don't play well together in the field. So we have a camp of people who study positive psychology, and it's really emphasizing things like strengths and positive emotions. Clinical psychologists cannot apply to grants for the positive psychology funding associations because they're separate. Similarly, the positive psychologists don't get to apply to the clinical grant money. And what this creates is yet another separation, and it forgets that this stuff is on a continuum. If we want to understand healthy functioning, we got to look at when it goes awry. And if we want to understand how to help someone who's gone awry, we got to look at when it's working well. And we don't tend to use this kind of continuous perspective. And people are really, just like we've got these people who are saying they're in the brain camp, and then there are people who are in the social camp, which is ridiculous. We've got similar disparities with people saying, I'm in the, positive psychology camp or in the health wellness camp, or I'm in the illness disorder camp.
The other thing I want to avoid is analysing this solely in terms of separable camps. I also want to bring it to the individual. That is, that we're in a situation where actually we've got conflicts within ourselves in practicing the best way we can. So, for instance, if part of the point of my case history, the second half of what I had to say, was to say, look, actually I took a particular stance in trying to investigate this person's difficulties. Now, there are times when that's actually not appropriate. In fact, there are times when I stop. And I think to myself, look, I'm dealing here with a more biological type depression, and I don't think this kind of work is relevant. We need another kind of orientation on this person's state at the moment. But that's a real difficulty. If you think about, say, presenting as people coming to We Three, we're actually going to meet you in very different ways. And it's going to show us things about you that are actually rather different, and we have a different lens, while still respecting that there are other ways of proceeding than those which we adopt. And that means one has conflict, and there's going to be a struggle, and there are going to be inevitable difficulties within ourselves, not just between groups, who seem to solve some of this difficulty by simply taking one view. It's easier for them, but it's not actually, I think, how we need to practice.
This was fascinating. Tyrone Foreman from Emory University. The question I have is about the social. In part, it's piggybacking off a comment that Peter made about social psychiatry or the history of social psychiatry. And there's a psychiatrist by the name of Jonathan Metzl who's written this fascinating book. He's at Vanderbilt, called Protest Psychosis: How Schizophrenia Became a Black Disease. And what he does in this book that I find fascinating is he basically chronicles from the beginning of the 20th century to roughly mid-century, late 60s, early 70s, the kind of demographic that was associated with schizophrenia. So if you look at the early part of the 20th century, most of the people that you find with schizophrenia in state mental health hospitals are middle-class white women, right, who forgot to do their chores and their husband sent them off to a hospital, right? You fast forward to the middle part of the 20th century, and those state mental health institutions, the population looks vastly different. It's African-American men, right? And what the argument that Metzel makes in the book is that while brain sort of medicalizing and having this notion that medicine, schizophrenia is a brain disorder. And the reason I think schizophrenia is important is I think there's lots of evidence to suggest this. How do you grapple with this sort of historical description in the state of Michigan, where he did his work, in which you have the sort of stigma of mental illness, sort of the population looking vastly different? And the other point on this is that what he does is he does a follow-up study. So after the state mental health hospitals closed down, what happens to the state mental health hospitals in the early 70s? They become prisons, right? And so that population of schizophrenic African-American men now stay in the same building that was a state mental health hospital, but now it's a correctional facility. And so I just want you to sort of think about what role does the social play in this, even for some of these mental health disorders that we have good evidence that there's a brain component to it or biological component to it. How does the social really function? And I think social, not just interpersonal, but sort of the broader culture.
I think that's, those are hugely important questions. And schizophrenia is a great case to look at. And I think there are a number of things to remember. And again, I'm not remotely dismissing the idea that the brain is clearly implicated in schizophrenia. But again, to date, we do not have a biomedical-based diagnostic criteria for schizophrenia. It's still diagnosed on the basis of symptoms, which I think immediately does bring the social back in. And we also have what some people sometimes refer to as sort of the schizophrenia paradox, where there seems to be some evidence to suggest that there are better outcomes for schizophrenia in some of the non-westernized countries that have lower rates of access to medications. And I don't think that's necessarily a medication issue as much as it may be that kind of social issue that you've talked about. And I know there's also been a fairly substantial literature on bias in diagnosing. So who gets diagnosed with what can be very much influenced by the factors that Peter is talking about. What lens do we bring to diagnosis? And so I think there are a lot of things there, and I think that is all the points you raised to me are just sort of further concern for simply saying these are brain disorders in a Cartesian culture. So in a culture that kind of uses that as a way to kind of reify, I think these really highlight really good, more reasons for concern. We know that, even currently there's, differential diagnosing patterns and also differences in how people are treated. So, if you are diagnosed as a child and you're in a lower SES, you're much more likely to be put on antipsychotic medications than if you are a child coming from a higher SES. And so I think, all of those issues are relevant. But
Well, I would agree with that. I'd particularly just highlight one element of what you're saying, namely that we need to keep doubting the thingness of our conditions, that which we give labels for. In this case, schizophrenia. That is, there's quite a lot of evidence that in different cultural groups, what a given person might say, yes, this person fits the criteria I use for schizophrenia, actually those represent very different conditions with different natural histories, with different responses to treatment. And so one, on the one hand, could say, yes, schizophrenia, look at it, this is now cropping up much more in this particular group. Or you could say, well, actually, we're using the word schizophrenia now differently for these social reasons, and indeed it could be for scientific reasons. You're studying different groups. And one has to keep this constantly in play. And I really want to go back to something that Bethany said about DSM, because I think DSM does a splendid job in some areas, and I think it's a bloody disaster in others. And I think, if you take something even as common as depression, it's so easy to slip into the notion that What one has is very serious depression, and then all this spectrum round to mild things like one meets every day, and this is all on a spectrum. Give it antidepressants. I've actually seen ECT given when I was a medical student to people who simply came and presented and saying they were feeling miserable. And in some ways, some areas, I have to say, I think depression is a whole myriad of very different things, subgroupings, whereas in other areas, I think there's something much more homogeneous, and one has to make judgments about this in the context of a changing cultural as well as a changing set of practices about diagnosis.
I agree with the comments that have been said. I would just add that I think it's a really important issue, but a challenging one to solve, because we actually see bias at so many different levels. So, Howard Garb and others have done work looking at when people are presented with the same kind of symptom presentation, that you see evidence of race bias, gender bias, age bias, and likelihood of diagnosis, including specifically with African Americans and likelihood of giving schizophrenia versus schizoaffective disorder and different diagnoses. Then we see bias in terms of likelihood of hospitalizations given those diagnoses. Then we see all kinds of other biases in terms of disparities in healthcare that people are receiving. And then we have to even take a step further back, which is that when you start to look at the research base that we are hopefully drawing from and making some of these judgments and decisions, there's bias there. So most of the research is being done on white majority populations. And so we don't even necessarily have the data to speak to whether different groups are going to respond in similar ways to the treatments that we think are most likely to be effective. So there really has to be change at so many different levels if we're going to effectively tackle this problem.